Hello everyone and welcome to Conversations in Lung Cancer Research, a TOGA podcast. My name is Mel Moore. I'm a medical oncologist at St Vincent's Hospital in Melbourne. I'd like to start this podcast by, on behalf of TOGA, acknowledging the traditional custodians of the land on which we live and work. We pay our respect to their elders past, present and emerging, and we also extend that respect to all Indigenous people. In today's episode, we're lucky enough to be joined by Professor Anna Nowak. Anna will be known to many in the TOGA community. She is the Deputy Chancellor Research at the University of Western Australia. She's a medical oncologist, clinical trialist and tumour immunology researcher with a long-standing research and clinical interest in malignant mesothelioma. She's a clinician scientist with interests in translational tumour immunology and imaging research. She's a Fellow of the Australian Academy of Health and Medical Sciences, a non-executive director of the Cancer Council Western Australia, and serves as an advisory council member for Cancer Australia. She's a member of the board of the International Mesothelioma Interest Group and is currently President-elect. Anna, welcome to TOGA's Conversations in Lung Cancer Research podcast.
Thank you so much, Mel.
Now, Anna, that was the bio that I read out, but to be honest, that really scratches the surface of what I could have read. We could have spent a good 15 minutes going through the pies that you've had your finger in, your achievements. And if we were talking about the creative world, you'd be the proverbial triple threat. You really have experience in such a wide range of medicine and research. I'd like to start by just, taking you back, and if you could just explain or reflect on your trajectory from what made you want to go into medicine and how you sort of ended up where you are today.
Yeah, thank you. The family law tells me that when I was about 4 years old, I said I want to be a nurse. And my parents, who were very much promoters of gender equality, said, well, you could be a doctor. And I said, oh, okay, then I'll be a doctor. So family law says that I made this decision very early on, but also coming from an environment in which an ethos of service and empathy was really emphasised, and what you could give back to the world and to society. So I did progress through school with, a goal in mind, and was fortunate enough to be admitted to medicine. This was in the days of undergraduate degrees where you did go straight from school to medicine. So I think many of us coming from that era have had a different experience to the highly competitive process of interviews and filling your CV that our young doctors have today. It really was purely on academic achievement at the time. I look back and wonder if I would have got in if I needed to be interviewed. I
was interviewed, and I say the same thing to myself, Anna.
But it was pretty clear to me from medical school and my early years in practicing as a doctor that I was travelling down a physician pathway. And some of the early experiences that I had as a junior doctor really triggered my direction towards oncology. So I spent a term in the breast cancer team. It was a surgical team, but the breast cancer team at St John of God Hospital, and just found that my communication style, I got a lot of good feedback from the patients. I had a lot of positive reinforcement when I was able to communicate with them about what they were going to experience in their breast cancer surgery, answering questions, supporting them through what was a very, very difficult period. A lot of them were quite young women. And I found the patient interactions incredibly valuable and important as a young doctor. Not only that, but of course the biology and the science behind cancer is the most, I think, complex and fascinating of almost all that we study in medicine. For most of these patients, cancer was a bolt of lightning from the blue, and how arbitrary and unfair it was brought out something in me that really wanted to contribute to their difficult journey.
I hear some of those things you're saying, and I think I had a similar experience as a basic trainee doing oncology, and those communications and those discussions, they're quite unique to oncology, I think, compared to some other areas of medicine. So really interesting to hear you say that, Anna. So you've completed medicine at University of WA and physician training, and then a lab-based PhD?
Yeah. So my motivations at that point were, I guess, the normal motivations of somebody who wanted to get a great job. I was looking to work in a teaching hospital. At that point, most of the interesting oncology in Western Australia was done in a teaching hospital. And I think we're in a different situation now where there's more growth in private oncology and in peripheral hospitals that can give you a really fulfilling career in those places. But it wasn't necessarily the case 25 years ago in Western Australia. So I had done some research with my mentor, Michael Byrne. He was Western Australia's first medical oncologist. And in fact, I believe he was Australia's first medical oncologist. And Michael had encouraged me to do some research in mesothelioma, then really guided me towards doing a more significant amount of research in order to set myself for both what he felt was what a fulfilling career looked like, but also to position myself well in a competitive world for a role in the teaching hospital. And originally, I wanted to do a PhD as a means to an end, but I fell in love with research. And the excitement of seeing new research born at the end of my pen or on my computer or as output of laboratory experiments was just so exciting and addictive. And I couldn't imagine a life in which I wasn't involved in research in some way.
Yeah, I guess, and the rest is history would be the cliche there. And I was looking up your Google Scholar profile, and I think you've had something like close to 30,000 citations, which is an incredible volume of output. So that early PhD really, obviously sparked something. Having done a lab-based PhD myself, how did you find the transition from clinical medicine to a laboratory-based situation?
Well, I look back on what my supervisors made me do, and they made me spend the first week pipetting amounts of liquid water basically onto a little mini scale so that I could be accurate in my pipetting. And they basically repeated that with any experiment I was trusted to do, made sure I got my techniques right first.
It's quite humbling.
Yeah, absolutely. But I continued to do half a day a week of clinical work, which I think was a great opportunity. And I certainly hope that most clinicians who are doing a PhD are able to keep a little bit of clinical work going. So that was really valuable. But I loved the self-motivation of the lab. I loved the pace of the lab. You could plan ahead. You could work as hard as you wanted to. Some people maybe didn't want to work that hard. I did want to work very hard. I was really focused on getting the outcomes, getting the results, pressing on with the next experiment. And it was really exciting to try to get as much done as I possibly could in the time available. So in many ways, I found the transition back to the clinic harder because it's unpredictable and your time is not your own. It's really hard to plan and you are at the mercy of what comes in the door and the situation that individual is in at the time, because you have to drop everything to be the right doctor for that person. And you can't plan what that looks like in advance.
Exactly. We are very lucky to have these jobs, but that is one of the aspects that is you never really get used to, is that unpredictability and inability to really plan your day. You never know how it's going to pan out. So imagining that during that time doing a lab-based PhD in mesothelioma that's obviously sparked your clinical interest in mesothelioma, and is that where you met some of, I guess, other clinicians with that same interest?
Yeah, it's hard to know what started first. Certainly my mentor, Michael Byrne, who was not a PhD supervisor, but he was my clinical mentor, was interested in mesothelioma. He did one of the earliest successful clinical trials in this disease. And because of all of the asbestos exposure in Western Australia through mining and milling of asbestos in Wittenoom and then the shipping. Mesothelioma had a really high incidence and still does in WA. So if you're going to choose a cancer to work on, it was almost a natural direction to go down because we had a great critical mass of people doing work in mesothelioma. So there were already experts in the field here, which was wonderful to learn from those people. And we had patients who not only shaped the clinical questions that we were able to answer in the laboratory, but also, of course, became the participants for clinical trials further down the track in my career. So I think it was just organic. Mesothelioma was a great opportunity in Western Australia and a place to be able to be on the cutting edge of work in that particular cancer.
So Anna, was it straight after that time that you spent some time in Sydney at the NHMRC Clinical Trials Centre?
Yeah, that's right. So I really had enough of doing work in mouse models. I think it can get very difficult work, particularly after 3 years. And so I decided to pivot to clinical trials. I'd always been interested in clinical trials, but we didn't have a centre of the size and stature of the NHMRC Clinical Trials Centre at that time, really anywhere else in Australia. So I was really fortunate to get a fellowship to go over there. I was actually the inaugural Clinical Trials Fellow at the NHMRC CTC, and there have been so many subsequently. But
I hope you've got a plaque, Anna.
Well, I did have to persuade Martin Stockler that it would be a good idea to have a fellow.
Well done.
And that was an incredible training ground. I'm sure it still is an incredible training ground in clinical trials, design, operations, biostatistics. Really encourage anybody who is there as an oncology fellow to soak up the incredible opportunity and experience that you'll get from not only the NHMRC CTC, but also other similar clinical trials units, either nationally or around the world. It's the only time you have in your career to really dedicate yourself to that work in quite that depth. And that gave me two legs to the three-legged stool of my career, I guess. In fact, it gave me, being a clinician, it gave me clinical trials, and I had the laboratory research as well. So that provided a really strong support and foundation for a career that I hope has been able to contribute.
So, and I think that's really, I was a trainee at RPA, I think around about that time. I think that's when I maybe met you or knew of you. And I think, correct me if I'm wrong, but were you also doing some psychosocial research as well during that time, or did that come after that?
Yes, during that time at the Clinical Trials Centre, there was quite a strong focus on quality of life research. And that was something that I picked up a couple of projects in and was able to contribute to. I also did the relevant part of the Masters of Public Health at the University of Sydney around patient-rated outcomes. And it added to the opportunities that were available in my career because I was able to speak the language of patient-rated outcomes as well as clinical trials. And that was during a period in which they were not universally incorporated into clinical trials. I was then able to transfer some of what I'd learnt there to my work in brain cancer, including a lot of qualitative work that I've done in collaboration, particularly with my close collaborator, Georgia Halkett from Curtin University.
And so then you went back to Perth, presumably. Were you doing a predominantly clinical role then, or was very mixed clinical research?
I went back to a clinical academic job, which was University of Western Australia and Sir Charles Gardner Hospital 50-50. That was what enabled me to do research because I actually had quarantine time. And of course, that university role also included teaching. So it was teaching and research in 50% of my time.
And at that time, I mean, you've obviously kept on supervising and being involved in laboratory research, but obviously also clinical research as well. Has that been a dual interest right from those early days?
Absolutely. I always wanted to be able to take the work from the laboratory through to the clinic. I would say that it's very, very hard to maintain your knowledge base in both laboratory and clinical trials all at the same time. So that needs very, very strong collaboration, great relationships. And I was fortunate to work with a lot of fantastic scientists and to be able to understand the language that they were speaking, to certainly, I hope, make intellectual contributions, but also acknowledge that it's really difficult to stay at the forefront of the basic laboratory science if you're also doing 50% of clinical work. So I really do want to credit the amazing scientists that I've worked with over my career.
And I guess that segues into junior oncologists or registrars coming through that think they might want to do the same thing. What, apart from having good supports and good scientists to work with, are there any other recommendations for how they would juggle those two career paths?
Yes, I've seen a lot of people try to juggle those career paths and take different directions. I was always quite strong with my boundaries around research time. So I did make sure that I invested in the training for the junior doctors on the team at the beginning of that rotation to ensure that they had the appropriate degree of training, autonomy, pathways. What I would do is spend that first couple of weeks of a new rotation really intensively supporting them with, I had presentations, I had almost SOPs, I had pathways, I had guidelines. I bombarded them with information so that they could be in some way autonomous and they could read my mind because I'd put down on paper what I wanted them to do in the number of different situations. And that was a great investment because it meant that they didn't always have to call me. They knew what my patterns of care would be. Also acknowledging that if you are 50% clinical and the rest of your time is spent either not working because you have other responsibilities or working in the private sector, you may not be available to pop down to the clinic in an emergency or even not an emergency. But there's an expectation that if you are a clinical academic and you also have a research role, that you're actually fully available during the time that should otherwise be quarantined for research. And I think we do have to reframe that. It is not poor medicine to reframe that any more than it is poor medicine to spend 50% of your time as a mother of young children or working in private practice or doing a different job. If you are 50% as a specialist, then being able to work at 50% I think is important. That doesn't mean lack of availability for emergencies by phone, but it does mean refining the expectations so that people don't think that you should always be down in the clinic.
And that's just beautifully elucidated that pull between different aspects of your life and even within your work life, private, public. I love that idea of SOPs. And do you know of anyone else that has taken that on and run with that? Because I'm liking that idea.
I have recommended to some of the people that I've mentored that they put something like this in place when they are struggling to, for example, complete a part-time PhD whilst they've got part-time roles. And what we do see is a lot of new oncologists, and I'm sure this is the same for other specialties, they might get a fractional appointment somewhere as sessions become available. So they have 0.5 or 0.6, but they end up actually working one FTE because they love their job, they want to do the best by their patients, and the service that they work for, whatever that is willing to let them do it.
Yeah, absolutely. If you do it, the powers that be are not going to complain, are they? If you're doing more than they're paying you for. And I'm just going to change tack a little bit. Many of our listeners would be aware of your role in mesothelioma research, and I guess the one that springs to mind is the DREAM study, which was an Australian-led study by yourself of first-line cisplatin pemetrexed and durvalumab in mesothelioma. I believe it was that you presented at ASCO and then subsequent publication in Lancet Oncology. Could you, using that as an example, I guess just for people that are out there thinking, I've got a trial idea, I might like to set something like that up. What were some of the challenges and the pitfalls and recommendations you would have for people that might want to go down that path?
I think it's really important to work with one of the National Cancer Cooperative clinical trials groups. And I know this is a TOGA podcast.
Well done.
Nobody asked me to say that. But I do believe that clinical trials are perhaps no longer the cottage industry that they might have been at the beginning of my career. So we were able to do independent small clinical trials when I started my career. And I think there are so many more pitfalls now, so many more regulatory requirements, data requirements, things that we're expected to do very well, very professionally, that it's very hard to do without having the professionalism of a clinical trials team behind you to do that. I would say that the Cancer Clinical Trials Cooperative Groups can be very good at bringing on enthusiastic young investigators. And if you do have an idea, that the more senior people in the group will hopefully often support and champion your idea and enable you to actually lead that clinical trial. So also saying this to those senior investigators as well, please give space for the new investigators who are coming along. And if it's done through a cooperative group, we know it'll be done properly. And we know that everyone else will be available to give the support and guidance that is needed.
Yeah, absolutely support those sentiments. So just to give people an idea, for a study like the DREAM study published in 2022, when was that first an idea, and how long was that from the idea in your head to publication? I'm suspecting a long time.
Yes, a very long time. So my PhD was in chemoimmunotherapy, and since that time I was doing chemoimmunotherapy trials, small trials in Western Australia, and a couple of small trials through cooperative groups as well. But clearly, when checkpoint blockade came along, there was a really obvious candidate to combine with chemotherapy. And the challenge that we had was that mesothelioma was a rare cancer, and the pharmaceutical companies that had these amazing new products were very lukewarm about providing their product, let alone any funding to study this important question in mesothelioma. And the irony is that the work in mesothelioma animal models was actually amongst some of the first chemoimmunotherapy work. So we pioneered this in the laboratory in animal models in sort of 1999 through to 2002, and continued to work on that. But when we had viable immunotherapy products with checkpoint blockade, the enthusiasm was to go to the big markets, the common cancers, the ones that were considered to be less risky or more treatable. And so, when did I start thinking about the DREAM trial? Oh, probably about 2000 I can't remember, probably about 2012 or so.
A decade.
A long time ago. And of course, the DREAM trial led on to the DREAMer trial, which has been our international randomized phase 3 study. And for various reasons, I was looking up my early emails on that, and we started we'd named the trial DREAMer and started discussing it in 2018. First patient in was in February 2022. And there's a long story behind why that took such an incredibly long time. I won't go into that today, but it's not unexpected to have significant delays between ideas and execution, unless there is a product and they are really keen to jump onto your idea. If you have to spend time persuading particularly the pharmaceutical industry to support your trial, when they're lukewarm about it, it's a much harder uphill battle.
So you really need to be prepared to play a long game for these sort of trials.
Yes.
And I just wanted to move on now to your role as Deputy Vice Chancellor at UWA, definitely the first Deputy Vice Chancellor that we've had on a podcast. How did that come about? Obviously, you've had a distinguished academic career, but that seems like was that a natural progression or a bit of a pivot?
I would say it's a bit of a pivot, but I can credit the National Cooperative Clinical Trials groups for sending me in this direction. Really want to acknowledge Mark Rosenthal, who was the chair of Cogno. And for a number of years, Mark was pushing me to become the chair of Cogno, to take over from him. And I think he had more belief in my leadership qualities than I had myself. And I kept saying, when my kids leave school and other excuses. But look, Mark did persuade me to take on the role of chair of Cogno, which was a huge privilege and which started me on a learning journey about leadership that got me quite addicted to that learning journey because I was striving to be a better leader. And I then saw opportunities to upskill myself in leadership in other areas and ended up deciding that that was a pathway that I really wanted to progress down. So I had some training opportunities that sparked ideas. I knew I didn't want to go on a leadership pathway in health because I didn't find it such a fertile area for creativity and innovation. It was much harder to get things done and to make change. And I wanted to be working in an environment in which I wouldn't feel stifled in that way. So initially I did some training. I did the consultant leadership development program with the health department through the Australian Institute of Management. I did Oxford Women's Leadership Development program, and I started a Masters of Leadership. And by then I'd really decided that that was the direction I wanted to go in. Initially, I took a role as 0.4 FTE Deputy Executive Dean and Faculty of Health and Medical Sciences at UWA, and that was only a short time before our faculties were dissolved. So it was during COVID, and a university restructure meant that my job that I was learning so much in suddenly was no longer overnight. And I had... with the departure of our executive dean, literally the following day, I then had a number of months where I was still trying to work in this role and transition towards a new structure in the university. After that, I was really fortunate to move into Pro Vice Chancellor Health and Medical Research role, still 0.6 at that point, I think maybe even 0.5. And at that point, I was still hanging on to some research, but also some clinical work. I did let go of my brain tumour practice, but kept the mesothelioma practice and, of course, still had clinical trials there. I was loving it, but didn't have any further aspirations. And with somebody else in the university leaving, there was a little cascade, a little shuffle of some of the roles. And I was asked to step into the Deputy Vice Chancellor research role for 6 months. So we negotiated me not doing clinical work for 6 months, and 6 months became 12 months. And I decided to apply for the role because I really was loving it and learning so much. I think it's also an opportunity to continue to use that service leadership ethos. It's different. It's not in service of our patients, but it is in service of the broader societal objectives of a university. So it's been really amazing to now be able to have hopefully some form of impact around supporting the research that's done in environment, in astronomy, in health more broadly, really across the full range of areas that our university has impact in.
That must be fascinating having deep dive into mesothelioma and brain tumours over a long career, and now the research world's opened up to include things outside the medical sphere even.
Yes, absolutely. I have to ask people curious questions about dark matter and quantum computing, and it's much easier in biology, I would say. So biology is quite transferable in many ways. I understand what they're doing in agriculture and plant science, and I understand what they're doing in psychology. But when it comes to near absolute zero freezes searching for dark matter, I need a lot of guidance.
Understandable. And is that your sole role now, or do you still dabble in some of your own research, or do your own research?
So I still work closely with the laboratory team, but of course they need to be extremely autonomous, and I'm really grateful that it's a group of people that I've worked with over many, many years. So I still have, I guess, intellectual input into some things that are, from my perspective, winding up, and they're doing new things without me. And that's great. That's where it should be. I still am involved in winding up the DREAMer trial. We're reporting on that. That's mostly after hours calls. And the IASLC staging committee for mesothelioma. So I'm still involved in that, which is answering research questions around imaging and staging, of course, although on quite a long time scale. So we go through the research part of it every 7 years or so. But there's a lot of preparation involved in that. I've really completely stepped away from brain tumour research, apart from providing input into the trickle of papers coming through from that. And over time, what I am doing will fall away completely. I don't have the capacity to continue with everything or anything new.
And I guess you must be starting to see people that you've mentored come through and taking on those sort of roles that you've left, perhaps.
Yeah, absolutely. I've been really delighted to see that someone who was a PhD student in mesothelioma has taken on the mesothelioma practice. Another one of the people I mentored as a fellow is also doing mesothelioma at another hospital, and has taken on some other leadership roles around telehealth, teletrials, and that's been incredibly gratifying. There are some wonderful new oncologists who also need opportunities. They need the rest of us to step away when the time is right and allow them space for their own careers to flourish.
Anna, we've been talking for longer than I had anticipated at the start, and that's just because it's been such a pleasure hearing what you've got to say. And that's probably a good point to stop on, that good point about mentoring junior oncologists and seeing them come through. It's been an absolute delight talking to you, Anna. I've learned things about your career. It's been great hearing about your academic career. You really are an inspiration to not just the lung cancer, the thoracic malignancy community, but to all of us, the way that you've shaped your career. And it's not over. Plenty more to go. So I really look forward to following where you end up next. I suspect Vice Chancellor, perhaps? Is that the natural progression? Maybe you can't comment on that.
Definitely no comment.
So thank you, Anna. It really has been a genuine thrill speaking to you.
Thank you so much, Mel, for your kind words and for your fabulous questions. Really appreciate it.
Thanks, Anna. All right, everyone. So that brings us to the end of this episode. As always, thank you for listening to TOGA's Conversations in Lung Cancer Research. If you enjoy our show, please rate and review us on Apple Podcasts or Spotify. And we look forward to you joining us for the next podcast.